This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. We're focusing this month on migraine awareness. With me to discuss is Michael Marmura, Associate Professor, Director of Outpatient Operations at Jefferson Headache Center, as well as the co-chief. Hi, Michael. Thank you so much for being on the Neurology podcast. I wanted to focus on refractory headache for Migraine Awareness Month. I think that there are a lot of advances in our treatments and therapeutics and ways of thinking about migraine, but there's still a lot of patients that are suffering. And there are a significant number of patients that might be disappointed with some of our treatments. Some of that might be because of suboptimal treatments or dosage or what we're doing as clinicians, but some of it just migraine is difficult to treat for a group of people. So why don't we start off with what would you define as refractory headache?
When we think about refractory migraine, we're thinking about patients who have migraine, most likely chronic migraine or even headache every day, that they're having at least 2 days a week or more of significant migraine, or they have to take medications, and that they've tried several established preventive therapies, in some cases, all of them. The definition of how many drugs do you need to have tried or used in the past to be considered refractory depends on who you talk to. But I think most people would say at least 3 good preventive therapies before you could be considered refractory. And this is a large proportion of the patients we see. I work at a center where most of our patients come in having daily headache or daily migraine and needing a lot more help.
I agree that the definition is a moving target, especially as we find better treatments for our patients. How do you view the comorbidity burden coming into play when we think of refractory headache?
Yeah, I think it's important to just really establish what's going on and get the diagnosis correct. So a lot of people have other comorbid medical conditions like depression or anxiety, and it's not clear if that's playing a part in making their treatment more refractory. In some cases, it's really a separate issue. So I think a large part of the first visit is really explaining the diagnosis, getting the right diagnosis, looking at other potential things that could be going on, looking for spinal fluid pressure problems or cervicogenic headache or another diagnosis like hemicrania continua or new daily persistent headache. And if the patient doesn't feel comfortable in the diagnosis, they're not likely to really accept the treatment either. That's a big part of the treatment. And then identifying significant comorbid medical conditions, whether they be a mood disorder or things like POTS, or gastroparesis or Raynaud's phenomenon, and considering those in the treatments is really important.
Yeah. And of course, there's the new daily persistent headache that patients sometimes have.
Yeah. And these are patients that they've never necessarily had migraine or headache. And usually they can remember the exact day or week when it all started. And it can be really overwhelming. If someone has had migraine all their life since they were kids, they often have really good coping strategies for managing migraine. But if you've never had headache before, it's really difficult, can be really difficult to deal with.
And we say that there are different trajectories. There are people that have chronic migraine that could be quite disabling. And this group, you put them on treatments and they respond quite well. And then you have others that you put them on a multitude of different treatments and very minimal response. What is your impression of stratifying these groups of people and why some people may respond to treatments while others do not?
I think that there's one possibility is for the patients who don't respond is we haven't found the right treatment for them, right? And maybe they have a reason for headache that we haven't found a good treatment. We've saw so many patients with these new anti-CGRP therapies that were refractory to almost every other preventive class who did really well with the newer treatments. So those patients would have been considered refractory. Now they're doing much better. The other thing that's difficult is if someone has migraine or headache every day, even if they find a good preventive treatment, they may still have headache every day, but maybe they'll have a few good days. So maybe they'll go from no good days a month to 10. That's actually pretty good if you think about it that way. But if you look at it the other way, they still have 20 bad days a month and only 10 good ones. So they're not meeting that 50% improvement that you'd love to see. And we know that with chronic migraine, most of the therapies, even the ones that are more than 50% effective in episodic migraine, are less than 50% effective in chronic migraine. So it's just a tougher group to treat. And so I often will start off saying, being that things are this bad, you might need a combination of therapies to get the best response.
Let's step back a little bit. Let's talk about some of our therapies and why our therapies are not working, or how we can better optimize therapies. Like, what is it that clinicians may be doing that may lead to this refractory nature?
One thing is you have to match the treatment to the patient. So if someone is having migraine every day or severe headache or chronic migraine, doing a low dose of one oral drug, for example, is probably not going to be very effective. Or even sometimes I'll see people say, let's try a supplement or riboflavin or magnesium. And so you really want to say, this is a serious problem. We need to be a little more aggressive. So you're maybe talking about saying, we're going to start one thing, but we may need to be more aggressive. The other thing that I think is often a problem is when you see a patient who's doing really poorly, that preventive therapy may take some time to work. It may take several months to work, but you might want to see them back much earlier than 3 months. If they have some partial response or they have a suggestion that they're doing a little bit better, you might want to increase the dose further or add a new therapy. And what we see with the newer drugs especially is that a lot of the patients who end up they do see improvement even the first month of starting these new, like the new anti-CGRP therapies. So I think that the standard, I'll see you in 3 to 4 months, may not work for refractory migraine, and they may need more frequent follow-up. And we'll often use things like our nurse practitioners to see them in the meantime and work with them more closely. I think it sends a bad message if someone is really struggling and doing poorly and you say, I'll see you in 3 to 6 months. Maybe you'll feel better by then. We need to see patients a little more often to get them under control.
So these are some great tips. One is underdosing therapies. Other is stopping preventive therapies probably too short of a time. And third is maybe not enough frequent follow-up.
Another thing is acute therapies. Even though you think with refractory migraine, most definitions don't include acute therapies, but if someone has an effective acute therapy, that does improve outcomes. So I think that while you're recommending preventive therapies and other things you can do, I think you at least want to consider using acute therapies in the meantime. In the acute therapies you might use for episodic migraine, where they have infrequent attacks, may not be as effective. The best example are triptans, which are probably the first line drug for people with episodic migraine if they have no contraindications. But for chronic patients, they don't do quite as well with triptans, and you might need to consider other therapies for those tougher to treat patients.
You were alluding to preventive therapies and combination approaches with preventive therapy. So I want to talk about that and your experience with refractory headache, as well as acute therapies and intractability.
I think with combination therapies, the nice thing about having some of the newer options is that you don't have the concern for some of the same drug interactions. So some of the oral drugs, some of them can be sedating, some of them can cause weight gain or weight loss. So they can be a little tricky to combine. So the newer drugs, the anti-CGRP drugs, are generally fairly easy to combine with other medications. They don't have as much of the weight changes or cognitive problems that we often see with other drugs. So they're often very easy to combine. And of course, we use a lot of, for chronic migraine, onabotulinum toxin injections are a great treatment for refractory chronic migraine in combination with other therapies. Often our patients are on oral medication and they're on either oral or injectable anti-CGRP drug, and they're on onabotulinum toxin A. So we're using several therapies at the same time. And then you can even add in other non-pharmaceutical therapies like neuromodulation devices or cognitive behavioral therapies such as biofeedback. So you're really doing all these things and really attacking it as aggressively as you can.
And then what about for acute treatment strategies? Let's talk about rescue therapies.
For patients who are doing well with triptans. Certainly that's okay to use while you're using preventive therapies. And what we see is that when patients are overusing triptans and they're taking them more than we would normally recommend, if you find a good preventive therapy, they stop using the triptans. Their medication overuse headache turns out not to be medication overuse because they got better with just using preventive therapies. We use a lot of nonsteroidals in migraine with chronic migraine. And I think that there's really no evidence that those medicines would cause rebound, but there often are safety issues from using chronic nonsteroidal drugs, but they can be helpful for people even if they have daily headache while you're trying to get things under control. We do use the antiemetics, the anti-nausea medicines, again, no risk of rebound. So with careful use, those medications could be helpful for refractory migraine. We generally don't use a lot of corticosteroids, but they can be helpful in a situation where someone has daily status migrainosus or daily migraine where they need to get some immediate relief. We'll also do things like occipital or other peripheral nerve blocks as a treatment for refractory headache, again, while you're trying to get their migraine under control. And then hydroergotamine is a great treatment for daily headache. It's given as an IV, as an outpatient infusion or in the hospital. And there are nasal sprays or injections available. And DHE is a good option for patients who did not respond well or they used to respond well to triptans. And finally, I think that even though they're not necessarily very effective for severe migraine or in terms of pain freedom, they can be useful for patients that have frequent headache or daily headache, where you're trying to give them some immediate relief while you're using preventive therapies. So we still use those even in our tough patients, even though they're not available as an IV or as an infusion.
You spoke a bit about using peripheral nerve blocks, possibly some G-pans. Can you give us a few of your favorite rescue strategies to break status, for example?
Yeah, I think one combination, if someone is, sometimes I'll use a nonsteroidal as a bridge therapy, and I'll combine that with an antiemetic like prochlorperazine. A lot of the neuroleptics are sedating, and they may have long-term side effects with frequent use, but I'll use them as a short-term treatment. I think most of us all use corticosteroids. Those, though, have to be limited. You can't use them too often, but we'll use those in a situation where someone's really refractory. And then the DHE, the dihydroergotamine, it does have a lot of potential side effects, nausea. The nasal spray can cause a lot of congestion. It can taste really bad. But it can be useful for people that really don't meet criteria for infusion, but they want to try something to get some immediate relief. And that's an alternative to trip for those patients with daily headache. So we use all those things. Yeah, some patients use other things. Some doctors use things like muscle relaxants on like tizanidine or baclofen as a short-term treatment. I think that we really do try to stick to the most proven migraine therapies.
And you jumped ahead a little bit to inpatient strategies. I do want to focus on that a bit. And I know you have a lot of experience with intravenous dihydroergotamine, ketamine, lidocaine, and of course, neuroleptics and other adjunctives. Why don't you talk about your approach to inpatient treatment, what patients you would admit, especially in the day of CGRP inhibitors and onabotulinum toxin A. So what patients you decide to admit and how do you choose inpatient treatment protocol?
And I think that some of the patients who have refractory migraine with these anti-CGRP drugs, they're getting enough relief and severity that they don't need to be admitted. They can still function, even if they have daily headache. So these are patients we would consider for hospitalization are people that are not able to function normally most of the time or more days than not, have severe disability, where they haven't found medications to be effective. They don't have good rescue medications when they have severe migraine. And there's other comorbid conditions that make it difficult for them to be treated as an outpatient. And often most of the time, they've tried outpatient infusions, whether they be in our center or the emergency room. They weren't very effective. We typically don't, with our center, I think that if someone might just do well with an outpatient infusion. They've only had migraine for a couple of weeks that have been like they're in status migrainosus. I think the outpatient infusion makes more sense. But for people that have been struggling for months and years, have serious medical problems or comorbidities, and have tried a lot of the outpatient therapies, I think the inpatient admission can be a game changer and a real life-changing experience for some of our patients. And the idea is if you find things that work for you in the hospital, that hey, some of those things we can use at home, right? So we'll often say if dihydroergotamine worked well in the hospital, they'll use that at home. If lidocaine IV worked well at home, they'll use something like mixilotine as a preventive at home. So we do try to use treatments based on, after the hospital, based on what worked while they were there.
And I think we should also talk about disability. It's probably not something that many of us get trained on in neurology residency, but there are a group of patients that are struggling. And we know that, at least for migraine, it can be a modifiable disorder, but there are patients that miss a lot of work and have financial impact. And so, how do you approach putting someone on disability? And I know it may differ from state to state, and
it's a very personal decision. It can be really traumatic for some people to lose their job. Some people, it's a big part of their identity. I think most doctors would say if they couldn't be a doctor anymore, they were disabled, it would have a lot of, not beyond the financial side effects, it would have a lot of psychological effects. So the first thing I usually will say is assess how people are doing in their job. And if someone's missing work and they're getting into trouble at work, they're not able to do their job as they want to do, there is, I think, the possibility of doing short-term disability if you plan on doing an intervention that will be effective. If you, however, have someone who's been sick for a long time, we may need to talk about longer-term disability. When people get better and they haven't been doing well for a long time, I usually don't tell them, I tell them that I don't think that the next step is work more hours. I usually want them to focus on something they enjoy. And if someone's been out of work for a long time and they're hoping to go back to work, let's see about doing something fun, or maybe exercising, or doing something that you enjoy, like a hobby, and making sure that you're able to do that first, and before you try to go back and work at a job where you won't be able to take off time or leave early in some cases. I think the working from home can be helpful for some of our patients. Some of our patients who would probably normally be disabled, being this ability to work from home has helped them control their environment and continue working, and maybe having some flexibility with their hours and not having to worry about, sometimes the commute is the hardest part if you have migraine, trying to drive on a sunny day, or when you're having migraine and you have to have half an hour to an hour of driving. So sometimes that can make a big difference for some of our patients.
I agree. It's important to think about flexible work schedules as much as possible, as well as accommodations, if that might be helpful. And it is a difficult discussion to sometimes have with patients, especially as patients improve, maybe not fully there, but improve. And then there can be sometimes fear of integrating back to work as well.
The accommodations is interesting because I think it's always better the patient and their supervisor know what they can do and not do. I've had times where patients ask for I need you to write so I can have this fancy workstation that's very expensive. And the company just said, we can't afford that expensive workstation. But I think if you know that, hey, would your boss be able to let you work from home if you're sick, for example? And some of our patients, even when they have migraine, they can do some work. They can answer some of the questions or emails or things like that, but they may not be able to do some of the more challenging things, or just commuting to the office might be difficult. Really encouraging. A lot of that is on the employer. Unfortunately, some people have jobs where this isn't really an option. If you work in as a fast food restaurant or clean houses for a living, unfortunately, these accommodations may not be an option. So even though it can help some patients and some other cases, it's not going to be realistic.
Can you give us some tips, Michael? We may talk about FL41 glasses, or how do you specifically try and target some of those symptoms?
For patients that have light sensitivity, there are several glasses that are maybe more effective for people with migraine. There's an Olay lamp, which is a green lamp that may be helpful for photophobia as opposed to being in the dark. And certainly with light sensitivity, there's a few things you can do. There are laws, most states have laws about how much tinting you can have in your car that's allowed, and you don't have to necessarily give people permission to do that. But I do tell people that with anything else, you want to kind of gradually increase your exposure. So you don't want to just rip off your sunglasses and run around if you're not feeling well, but you also don't want people to be, what we see is trying to avoid things in chronic pain tends to cause more problems than helps. So I definitely encourage patients to stay active as much as they can. And some light exposure may be better than none at all. And not to restrict their activities as much as possible. If they are feeling good and if they're having refractory migraine, that maybe that even if they aren't feeling well some of the time, if they have some days where they can at least have plans to do something fun or interesting, that does tend to help rather than telling people to try to sleep or try to avoid things as much as possible.
And we spent a lot of time talking about the pain components of migraine, and it's defined by response to treatment and reduction of pain, but we don't focus enough on associated symptoms such as persistent photophobia that some patients may experience that sometimes may be more than the pain itself. And so how do you approach patients that have persistent photophobia? We can talk about other associated symptoms like nausea, for example, but how do you deal with some of these associated symptoms in addition to treating the migraine itself?
Yeah, I think that the first thing is you have to make sure you understand it and document it. So if you write in your note that they're only having mild headache, where they maybe have mild, the headache pain is mild, but they're disabled because they can't look at a computer screen for more than a few minutes, you have to say we still need to be aggressive in treating migraine because that's also a problem. You definitely have to ask about these things. And sometimes it's not just the light sensitivity and sound sensitivity and nausea. It's often things that maybe are not as common, like vertigo or vestibular migraine or abdominal pain that can be associated with migraine. So you have to address those issues too. And then sometimes you may have to be more aggressive with the treatment.
Thank you so much. I think this was a very fruitful conversation, and we spoke a lot about different strategies to help people with so-called refractory headache. And I really hope and pray that in the future, this word refractory headache would be completely revised, because what we call refractory headache would be a thing of the past. I think it's important to think about getting patients in sooner and using physician extenders as much as possible. Think about the different strategies that we have, the inpatient modalities, the procedural aspects, and maybe even other colleagues in GI clinics or ENT that might be useful, physical therapists that might be helpful, in addition to the pharmacology and the counseling that we give to our patients.
Yeah, there's so many patients out there with refractory migraine, and there's only a few hundred headache specialists. We definitely need to work together with other specialties, as you mentioned, to get the best results for our patients.
Thank you again for being here.
Thanks, Tesha.
Thank you for listening to the Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.